So now let's get into arterial disorders, okay? So let's first talk about arteriosclerosis, and then we'll talk about atherosclerosis, because there is a difference, but the results of it, the manifestations, is pretty much the same, okay? So arteriosclerosis. The general term for degeneration changes in arteries make them less elastic. This is something as we get older, it's just going to happen, okay? We can't really change much of that. Basically, the blood vessels have a lifespan. If you leave your nice Porsche car in the field over there and leave it there and don't drive it and leave it there for 10 years, the Porsche car will be fine, but the tires will still rot away, right? So the tires have a certain lifespan that you can't do anything about that, okay? Same thing with our arteries. It becomes, it has a lifespan, and it does do these changes as we get older. So we can't do much about that. People who have arteriosclerosis, they're at risk for CVA, a stroke, hypertension, coronary artery disease, which is the #1 killer in America because it leads to myocardial infarctions, heart attacks, and also complicates the vascular disease and becomes peripheral vascular disease, which we'll talk about. Okay? Now, atherosclerosis. Atherosclerosis is something we can do something about. This is going back to the HDLs and LDLs and all that stuff, the cholesterol. Basically, the cholesterol going into the arterial walls by way of the LDLs, the low lipid protein, low density lipoproteins. They are going to cause these things called atheromas. Atheromas are the cholesterol actually building up in the arterial walls due to the LDLs. This will obstruct blood flow, as you can imagine. So as it gets narrower and narrower and narrower, the lumen of that blood vessel, that'll cause ischemia, less blood flow to that area. That'll eventually cause an infarction, which can cause a myocardial infarction or a stroke, or anywhere that blood is supposed to go to is now going to have some kind of hindrance getting there. 70% of blood vessels is occluded before clinical symptoms appear. That's a scary thing, all right? Usually when they find out that there's something wrong with the blood vessels, it's already at a very late stage, okay? So keep that in mind. This weakens the arterial wall, all right? When you have an aneurysm, which is a dilation, it weakens, it'll rupture, okay? So basically what's happening here is that if you have, I'll draw this again for you. Okay, so there's your blood vessel, and what will happen is you're going to have an area where maybe, okay, so this is, let me draw this. I'm exaggerating this just so you can see what's going on. What's happening here, if this is your normal blood wall over here, the dilation here, it balloons out and becomes very thin over here. If there's atherosclerosis that's occurring around here, that's going to actually thin out this wall, or at least it's going to weaken the arterial wall. It'll crack a little over here, and this will get, so these could actually blow up bigger and bigger and bigger, and that will rupture. Okay, which is one of the leading causes of stroke deaths. Okay, but we'll get more into aneurysm in a moment. Okay, so it weakens arterial wall, aneurysm, which is a localized dilation of a blood vessel. Okay, that can lead to an arterial rupture, and that can lead to hemorrhage at that wherever that blood vessel is. All right. So this is just showing you again. This is what a normal blood vessel should look like, the lumen. But if we have the yellow area here where the atherosclerotic plaque is, you can see that it's going to narrow the lumen, decrease the amount of blood flow to wherever this organ is over here, whether it's the heart, the kidney, the brain, and so forth. Okay. Eventually, that you have fatty streaks in there leads to a plaque, which eventually will lead to a advanced plaque, which will have a narrow lumen. Okay, so growing thing over here. Again, and that's what they're talking about. You know, they usually don't get symptoms until about 70% of this blood vessel is occluded. Occluded meaning that it's going to be blocked. Okay. Just another picture showing the same thing over here. All right. And you can see that. Okay. There's different things over here you should just see. When you look at a microscopic level, this lumen here, this is an artery. This lumen here should be nice and round, but there's an atherosclerotic plaque that's building up over here. That's what this is over here. Okay, you can see over here a cut artery. This should be round, but there is an atherosclerotic plaque that's building up in this area over here. Okay, some risk factors for atherosclerosis is hypertension, just having high blood pressure. Maybe it's due to cholesterol. You have too much cholesterol itself, hyperlipidemia, smoking, obesity. As you get older, it's hard for that liver to break down the cholesterol. You would want it to, but as we get older, it just becomes less functioning. Family history with atherosclerosis. Mom, dad, sister, brother, you have a greater chance of getting it. People who have diabetes, men more than women, and also postmenopausal women are all at risk of, high risk of getting atherosclerosis, okay? Complications of atherosclerosis account for approximately 50% of deaths in the United States. Like I said, this is the leading cause of deaths in America. At least it's atherosclerosis to the heart, right? The coronary arteries. And that's what's happening. So how do you treat something like this? Well, we can do a percutaneous transluminal coronary angioplasty. Angioplasty is a fancy word for angio, meaning blood vessel. Plasty, you're going to reconstruct it. You're going to change the anatomy of it somehow. Surgically, you're going to do that. So we need to remove the plaque from the coronary artery. Okay, and you get a catheter that's put into the femoral artery and brings it up, threads the catheter up to the area wherever that atherosclerosis is, and they do different things. I'll show you what some of these are. You could do either what we call balloon angioplasty, where a balloon is going to spread, blow up at that area right there, and I'll show you that. Or we could do a stent placement. I'll show you that in a moment. It's much easier to show you. Okay. Or we could go in and just cut out that plaque. Usually they do it in the carotid arteries over here. So this is balloon angioplasty. They put this catheter in. The catheter is like a long wire, and at the end of the wire there's a very small balloon that they could blow up from the outside of the person's body. And this is all on a procedure that's usually done in within a half an hour or so. So they put this catheter in, usually from the femoral artery, but it depends on where we're going to need to go to, right? So you put this catheter in, it gets to the part where the atherosclerosis is, and then we blow it up a little, so it kind of pushes. It doesn't remove it. It kind of pushes the atheroma to another area, right? It just pushes it out. Kind of like pushing Play-Doh, right? You're pushing it. It's like a clay, that kind of thing. So we can do that, and that opens up the lumen. That's only a temporary fix. I mean, they still need to do exercise. They got to cut down on the cholesterol and so forth. Otherwise, they're going to have to do this again, right? This is a stent placement, and they can do this too. Basically, they put in, again, another catheter goes in, and the catheter goes into the area. And at the end of here, they have like this mesh. The best way I could explain, I don't know if you've been to amusement parks or arcades. I don't know if they have arcades anymore. But you win these things, and they're called Chinese finger handcuffs, so to say. and you put your fingers in here and you try to get it out and you can't. It's like a weaved area. That's what basically this is. Is that they put the catheter, the end of the catheter, at the place where the atheroma is, and then they release the stent there, and the stent opens up, and the catheter is removed, and the stent actually stays there, and it kind of opens and presses against the atheroma. So it kind of does the same thing here, except something is permanently there, okay? And it kind of opens it up. Again, they got to still do other things to make sure they don't build up more and more atheroma. So they got to do exercise, they got to cut down the cholesterol, and so forth, right? So that's what a balloon angioplasty is in a stent placement. And they can put that not just in the heart, the coronary arteries. They can put it in other places, right? The renal artery, other places wherever that atheroma is. And a carotid endarterectomy is basically you're going in as a surgeon, you're going to go in, cut that area, and literally remove the plaque if it's that big. Okay? And they usually do that in the carotid artery. Our biggest concern, of course, if the carotid artery gets occluded all the way, 100%, then that's less blood going up to the brain, which means you're going to have a stroke, right? All right, so let's talk about hypertension. Ooh, okay. Hypertension. Now, these levels you do need to know. I guarantee it. Now, I have to say that this here, if you look at your book, the book is going to be different because this is the most recent criteria that was put together by the American College of Cardiology and the American Health Association. This is what we're going with now. This is what's going to be on your test for my class, what's going to be on your test for your other courses, and for the NCLEX. All right, this changes well, it seems like it's changing like every 7 years or so. But this one is, the most recent one is from 2017, and you need to know these lab values. Not really lab values, but blood pressure values, okay? So normal is anything less than 120 systolic, and diastolic, it has to be less than 80. So notice that there is an and there. Less than 120 and less than 80, right? So I guess about 10 years ago, we always said, oh, an ideal blood pressure is 120 over 80. Not anymore. They realized that people with blood pressure 120 over 80, that they tend to get high blood pressure earlier than other people. So what an ideal one we really want to get is a blood pressure 115 over 75. That's a good blood pressure, okay? It's elevated if it's between 120 and 129 and it's less than 80. So these can get a little confusing. Make your cards or something, but they will be asking you these in the NCLEX, and I've got to get you trained for that, so it'll be on your test too. Don't worry, on your review questions, there's a few on there also. Now, stage 1 high blood pressure is 130 over 39 or 80 to 89 for diastolic. Okay? High blood pressure stage 2 hypertension is 140 millimeters of mercury or higher, or 90 or higher for diastolic. Okay? We also have something called hypertensive crisis. So even though these are higher, if this should reach more than 80 systolic and or the diastolic is higher than 120, then that's good enough. If we see a blood pressure is 120 in the doctor's office, of the diastolic of 120, we're going to do something with that patient. We don't want them to be sent home. We'll probably send them off to the emergency room from the doctor's office. We don't want to, most, and you're going to see that the most common presentation of someone with a blood pressure of, with a diastolic blood pressure of 120 is asymptomatic. They don't even realize it. They're just walking around and not realizing that they're taking time bomb. That if they have, let's say, a diastolic of 120, there's a chance that they might just stroke out. I don't want anyone to stroke out of my doctor's office. We picked it up. That's why we do blood pressures. I'm sure all of you have been to the doctor's office, and they always check your blood pressure. Well, I feel fine. I feel fine. Why do you always check my blood pressure? Because these are the things that sneak up behind you. They don't realize it. Most people are, like I said, asymptomatic, so they want to catch it. Okay? So anyway, these are the values you definitely need to know for my test, for your future courses, the NCLEX, whatever you're going to be doing in the future. Okay? You shouldn't be going into a book, if you're looking at someone's blood pressure and saying, oh, your blood pressure is high. You should have these memorized. Okay? Now, like I said, an ideal blood pressure is 115 over 75. So let me just show you some other examples so that you can see how to use this. The way we define or we diagnose someone with high blood pressure or hypertension or normal blood pressure, you've got to get 3 readings within 1 week apart. Okay? You could go and have the blood pressure done at your home and get one of those kits. You can do that at home. You could go to Walmart. They're pretty dependable also, reliable also. Go to Walmart, just get them done over there. Or you want to go see your doctor or clinic, wherever you need to go. But you got to get 3 readings because there might be something that it might be a little bit off just because we call it the white coat syndrome. Your blood pressure is a little bit high because someone's doing your blood pressure. You're not in a happy place because there's needles and gets no rubbing alcohol. So that could get your blood pressure up. You hear screaming, maybe the other room over there for some reason. So we like to get 3 readings in, with 1 week apart. Okay? So use a systolic or diastolic pressure that would put that person in the higher stage, as I showed you in the one before. So an example, if you have 135 over 77, that would be stage 1 hypertension because the 135 is what's putting you into that area. Even though 77 is not, you've got 135 that is much higher, right? Another example is 150 over 88, that's stage 2 hypertension, okay? Because this is above 140. You see what I'm saying, how you work this out? All right? I do want to mention, too, the hypertensive crisis. Just emphasize it. If you see a diastolic of blood pressure that's greater than 120, let's say in a doctor's office, at home, or whatever, that's good enough to do it for just 1 time. You don't wait another week and get 3 times. All right? So if you have a blood pressure that's 168 over 124, you got to do something right then and there. Okay? So that just gives you an idea of these, how to go about doing this. Okay? Questions about that? Okay. All right, so there's 2 types of hypertension. There's one here called essential or primary hypertension. This is what most people have if they have hypertension. 95% of hypertension is this. It's essential. And there really is no reason of how they got it, okay? It could be atherosclerosis, it could be arteriosclerosis, but how they actually got it, they could actually pinpoint it, and you can't find out. So what we call this is essential hypertension or primary hypertension. And 95% of hypertension is idiopathic, okay? That leaves the other 5% where we could find a definitive cause for it. Where is that, the atherosclerosis? Where is it exactly? So 5% has some identifiable cause. The most common reason for secondary hypertension is renal stenosis. that there's, in the renal artery, it's stenosed with atheroma, which means there's less blood flow going to the kidney, and that's going to lead to other things. We'll spend more time talking about renal stenosis when we get to the urology disorders. Chronic renal disease can cause this, diabetic nephropathy, all right? Nephropathy is kidney disease due to diabetes, okay? Conn syndrome, Cushing's syndrome, acromegaly, hyperthyroidism, pheochromocytoma. Certain medications could also make your blood pressure go up, and the list can go on and on, okay? But believe it or not, this only makes up about 5% of people with high blood pressure, okay? Most cases is an idiopathic cause. We call it essential hypertension. So really brief about renal stenosis, which is the most common cause, MCC, most common cause of non-essential hypertension. It's due to atherosclerosis to the renal artery. So if you decrease the blood flow to the kidney, you decrease the blood pressure to the kidney, which means that renin is going to go up, which means that your blood pressure is going to go up. Okay? We talked about that with the renin, angiotensin, aldosterone mechanism. But we'll talk more about this. This is just a brief understanding or quick review, but we'll go more into details about this with the urology. Okay? All right, so let's talk a little bit more about essential hypertension, right? Remember, it's 95% of all hypertension is idiopathic. It affects nearly everyone eventually because everybody's going to get arteriosclerosis. As I explained to you, the tires of the Porsche will just normally rot away, right? So risk factors. The high salt diet is the biggest environmental risk factor. People just eating a lot of drinking or eating a lot of salt, they're the ones that are going to have hypertension more often. All right, so we got to cut down on the salt, and that's been branded when we were kids. You know, too much salt is not good. And you'll be surprised at like soda how much salt is in there. Okay, not just sugar. I'm talking about salt itself and the sodium in it. Saturated fatty diets, African Americans, genetics, obesity, chronic stress. So I can see your blood pressure going up for this class. Diabetes, just being a couch potato, smokers, oral contraceptions. All of this can increase your risk of having high blood pressure. Okay? Some symptoms of this, as I mentioned to you, most cases it's asymptomatic. People are walking around like little ticking time bombs, but their blood pressure is very high and they don't realize it. Okay? So most patients are asymptomatic. All right? Usually the hypertension is found as an incidental finding in the doctor's office. Okay? Just doing a routine exam. Some vague symptoms, if they do have symptoms, lightheadedness, tinnitus, they either get this ringing or buzzing in their ears. Okay? Nocturia, that means, and we'll get into that with renal stuff, but nocturia means that you're going to the bathroom, going to urinate many times throughout the night, all right? You get tired. You can also have palpitations. Palpitations is the feeling that you could actually feel your heartbeat. Now I'm putting your hand over here. You could be standing here, and I'm feeling my heartbeat, pounding. So these are some symptoms, should they have symptoms, but the key here is that most patients are asymptomatic. Okay? So complications that can occur, pretty obvious ones. You could have a stroke, a heart attack, or you could have kidney failure. Okay? Amongst other things, but these are the biggies that you should know. Okay? So let me do again some review from A&P2. The mean arterial pressure, okay, so we call it the MAP. But the mean arterial pressure, you should be able to do this formula. Yes, there could be a question on the test over here. But I want you to see why high blood pressure is bad, or how they calculate this. Now, there's a few different formulas, right? Again, this should be reviewed from A&P2. There's a few different formulas. This is the one that's probably the easiest one to work with when you have a blood pressure that is given to you. And what it is that we take the diastolic pressure plus the pulse pressure divided by 3. Okay? What this is telling you is that the mean arterial pressure, which is basically the arterial pressure of all your blood vessels throughout your whole body. Some places it's higher. Obviously, the ascending aorta, it's going to be very high. By the time you get to the venous system, it's going to be very low. But we're looking at the average. And that's what we're looking at with the mean arterial pressure. That this emphasizes that the diastolic pressure is much more significant than the systolic pressure. In other words, the diastolic pressure is what's the pressure that's in your blood vessels when it's at rest. Whereas the systolic is what's your blood pressure like when it's, when there's a bolus of blood that just went into it, when it's under pressure, right? When the heart contracted. So what they do is a diastolic pressure plus 1/3 of, you take the systolic pressure minus the diastolic pressure. So with this, and I'm going to show you an example, so we'll do this together. So the systolic pressure minus the diastolic pressure is known as a pulse pressure. So I just rearranged it, made it easier for you to see it, but I want you to see where I got this number from. So the diastolic pressure plus 1/3 of the pulse pressure. So let's do one together, okay, so that you can see what's going on here, okay? And this is just showing in the map, essentially, okay? So, if we have a blood pressure of 115/75, is this normal or is this abnormal? It's normal, right? That's what you want, is an ideal blood pressure of 115/75. All right, so we plug in all the numbers. So the pulse pressure is going to be systolic pressure minus the diastolic pressure. So we're going to do 15 minus 75, which you get a pulse pressure of 40 millimeters of mercury. Then you take the formula, right? So you're going to take the diastolic pressure plus the pulse pressure divided by 3. So you take the diastolic pressure, 75, right? And then you're going to take the 40 divided by 3, and you're going to get 75 plus about 13. You get a mean arterial pressure of 88 millimeters of mercury. What that's saying is, on average, in a person who's got a blood pressure of 115/75, on average, their blood pressure is 88 millimeters of mercury, okay, at one given time. That's what I'm saying. It's right there. So these blood vessels should withstand a blood pressure on an average of 88 millimeters of mercury. Okay, just to give you an idea. Now, let's do another example, and we'll get back to this one. Let's say a person's blood pressure is 160/100. Okay? We're going to use the same formula. The pulse pressure is 160 minus 100, which means you're going to have a pulse pressure of 60 millimeters of mercury. Then we take our formula of MAP, and we take the diastolic pressure, which is 100, plus 1/3 of 60 is going to be 20. Now, the mean arterial pressure is 120 millimeters of mercury. Now, the one I showed you before, it was 88 millimeters of mercury. On average, that's what your blood pressure is doing, right? In all your blood vessels. But now, in a person who's got a blood pressure this high, on average, that's what your blood vessels are holding. Think of your tires of your car. If it's supposed to take 35 pounds of air in there, air pressure in there, now you want to put 60 pounds of pressure in there. Those tires can't withstand that pressure. 60? It's almost double. So what do you think those tires may do? Yeah, they're going to burst. Same way here. The blood vessels can burst if you keep up this high blood pressure. Okay? If it's in the brain, one of those blood vessels then will burst, cause a stroke. You see what I'm saying? Okay? So that's the significance of this. Is that example, 115/75, the blood vessels can withstand a normal average blood pressure of 88 millimeters of mercury. But if you have someone, let's say 160/100, that gives the blood vessels are now experiencing an average of 120 millimeters of mercury of the blood pressure. chronic hypertension, make blood vessels more likely to burst, think stroke, right? Think of those complications that can happen wherever that blood vessel is going to, okay? That would be that would cause a hemorrhagic stroke, right? Does that make sense? Hemorrhagic, it will burst and blood will be going all over the place, right? As opposed to ischemic stroke, which is less blood going to that point. That would be more concerned about an atheroma, right, of the carotid artery. There's less blood flow going up there that can lead to a stroke. In this case, it bursts, so now the blood is going all over the place and not going to the brain itself, and that's a hemorrhagic stroke. So we have ischemic stroke and hemorrhagic stroke. That's what that is. Okay? So treatment for this is there's no cure. Okay? If hypertension, all right, whether pre-hypertensive or stage 1, with no comorbid diseases, meaning like they don't have anything else like diabetes or they haven't had a stroke before, that kind of thing. You just have, and it's an incidental finding on a healthy person. In other words, all they now have is high blood pressure. Then basically what they're going to do for about 6 to 12 months is just tell them to do a lifestyle change, see if that works. In other words, change your diet, eat less salt, don't eat so many fatty foods, cut down your cholesterol, do exercises, stop smoking if you're smoking, that kind of thing. And they'll do that for 6 to 12 months, okay? If it doesn't go down after 12 months or so, then they're going to put them on medication, right? If hypertension, okay, stage 2, or there is a comorbid disease, in other words, with stage 1, does that make sense? So you could have stage 2, or pre-hypertensive, or stage 1 with a comorbid. Then we'll do lifestyle changes. We'll always consider doing that because that's free, right? You'll probably be on you will be on some sort of antihypertensive medication, some diuretic medication to cut down on the blood volume but making you pee, okay? And perhaps we'll give you some kind of vasodilators, some kind of medications that will help expand the blood vessels, which will decrease the blood pressure. Won't go heavy with all this. This is more like pharmacology, but I do want you to understand when would you give pharmacology, some kind of medication, is if you have stage 2 or it's stage 1 and has a comorbid disease like diabetes or something like that, okay? Or if they had a history of a heart attack, things like that. Okay, so that's what I want to say about hypertension. Now let's talk about something called orthostatic hypotension, okay? Some people call it postural hypotension. This is the feeling that basically your blood pressure is a certain way when you're lying down, and then when you get up, your blood pressure drops, okay? Hypotension. Some people, when they lie down and just have them get up, even not doing any blood pressure, they feel weak. It's because the blood pressure went down. So we call this orthostatic, a change in the blood pressure. That's what orthostatic means. It's static means that it changes, okay? And postural means like you're standing up. So this is a decrease of blood pressure upon standing from a lying position. And I do want you to know the proper steps to do this, all right? You see so many nurses, medical students, they're doing it the wrong way. Even doctors are doing it wrong. This is the way you have to do it, okay? And this is also good if you're at home and you don't know what to do. You know, your mother is complaining of something or it doesn't look, you can do this at home. And then these numbers you can give to the paramedics when they come to you, have an idea of what to give them. Yeah, she's also orthostatic, she also has a orthostatic hypertension, and that gives them a better clue so that we, what they need to do when they get to do what they need to do. Right? So what you do is, while they're lying down, take the blood pressure and heart rate while you're lying down. Okay, so if they're comfortable, they're lying down. Then stand them up or her up. Okay. Now, if they're on edgy, I understand they won't be able to stand up, or if they can't get stand up, no problem. Just let them sit up, but let them dangle their legs on the side of the bed. All right, so that the blood pulls down to the feet. Does that make sense? All right. So I understand some people, their arthritis, they can't really get and stand up, but you got to change them. So take the blood pressure and heart rate while lying down, have them stand up or let them go on the side of the bed and let their feet dangle. Wait 3 minutes. That's the biggest issue that people don't do. They do it immediately, the blood pressure. No. You need to wait 3 minutes to have the body adjust to that new position. Whether they're standing up or they're on the side of the bed with their feet dangling. After the 3 minutes, then repeat the blood pressure and heart rate. If the body has adjusted to it, they don't have orthostatic hypotension. But if there isn't much of it, if there is some sort of change, a big change, then we have that. So these are the results of a positive results for orthostatic hypotension. If the change means that there is a 20 millimeter, let's say on the systolic pressure, it drops down 20 millimeters of mercury. Or the diastolic, it drops 10 millimeters of mercury. Or the beats per minute, right? BPM is beats per minute. The heart rate increases 30 beats per minute. Your blood pressure goes down. That means your heart rate is trying to compensate by beating faster to get the blood there because there's less blood. Does that make sense? So your heart is going to beat faster. That's why your heart rate will go up, but your blood pressure will go down. But these are the numbers. If they don't go up, if they don't fall into these categories, they don't have orthostatic hypotension. All right? So make sure you know the steps to do this. Wait those 3 minutes. Okay? And these are the numbers that you should know. Okay? Doctors will ask you to do this. As a nurse in the hospital, we'll check his orthostatics. That's what they'll say, orthostatics. And that means do the blood pressure lying down and standing up, but waiting those 3 minutes. Okay? Questions about that? No? Okay. All right. So what causes this? Well, if you have a massive hemorrhage, you know, got in a car accident or something, you lost a lot of blood. Okay. So you can do that. Certain medications, alpha blockers, which you'll learn about later on. Certain medications will actually cause this, or autonomic neuropathy. All right. I'm going to go into details about this, but there's some reason why the nerves do that. It's the autonomic nervous system that does that. Okay. So that's what those are. Some symptoms, obviously, they're going to get very lightheadedness. You know, when you stand up, it's like, whoa, you know, because all the blood just rushed down and pulled down to the feet. They'll get syncope. Maybe they'll have a brief episode of fainting or loss of consciousness because of the blood just rushed down from the brain and now moved down over there. Okay? Complications, obviously, you could probably put this all together. You have a decreased blood pressure, which means you're going to go into hypovolemic shock, which means there's less blood flow going to certain organs, and that could lead to death, depending on what organ we're talking about, or organs we're talking about, kidney, brain, heart, and so forth. Okay? We've got to try and fix what's happening over here. If their blood volume is down, then we may need to put more blood in them, or more fluids in them, or albumin, right? It's going to bring more fluid into the bloodstream. Okay? So you need to know what those are, or change the medication that you need to.